Hello everyone. Today we are discussing another very important topic, and that is amenorrhea. So in this lecture, first we'll discuss the primary amenorrhea. Extremely important. I don't know why, but NEET-PG and INI-CET examiners are going crazy behind these topics. Diagnosis, then the evaluation based on symptoms are asked like anything, especially since past 2 to 3 years. Lot of questions are being asked on amenorrhea. So let's start with primary amenorrhea first. First and foremost, definition. Very important. Many times questions have been asked. What is primary amenorrhea? Any girl who has not developed the secondary sexual characters and the menses both within 13 years of age. And if somebody has developed secondary sexual characters, then you give her a leverage of another 2 years. So if there has been secondary sexual characters but no menses till age of 15. So we have two age groups. So I will repeat. If a girl comes to you at age of 13 with no secondary sexual characters, no menses, you will evaluate her at age of 13. Suppose this girl comes to you at age of 13 and she says that secondary sexual characters are present but menses has not happened. Then you say ki, see, secondary sexual characters has happened. We should wait another 2 years to see whether menses will come or not. You have got hormones in your body, that is why secondary sexual characters have developed. When I am saying secondary sexual characters, I am basically talking about thelarchy, the breast development. So if that has occurred, we ask her to wait for another 2 years so that menses can happen. Now menses do not happen even after 2 years, that is 15 years of age. Now she needs evaluation. So we have two age groups. Also one more definition is there, that it is said that after thelarchy, menarche, the menses should happen within 3 years. So if the thelarchy is not followed by menarche after even 3 years, then also that is a case of secondary amenorrhea. Then also it is a case of primary amenorrhea. So definition is clear. There has been questions, so you have to be very clear with the definition. One thing I want to mention, previously this age group was 14 and 16. But as you know, when the diet improvises in a girl, so when a girl will attain menarche depends on a lot of factors. It depends on her mental status, it depends on her physical status, it depends on her mental status, on her physical well-being. A girl who has nutritionally been very well starts menarche early. So previously this cutoff was 14-16, but then it was eventually seen that because of good diet, these days girls are attaining menarche at a little earlier age. So now the cutoff is 13-15. Okay? So now how can the amenorrhea be classified, be it primary or secondary? So for menses to occur, there are 4 structurally and functionally different departments which need to function properly. What are those departments? We need properly functioning hypothalamus, which will release gonadotropins and it will act on pituitary hormone. Pituitary hormone will release FSH, so hypothalamus will release gonadotropin releasing hormone. Pituitary will release gonadotropins, that is FSH and LH, unko hum kehte hain gonadotropins. They will act on ovary and that will act on your genital tract. So these are 4 departments which have to work properly in conjunction with each other so that menses can happen. And problem at any of these level will lead to amenorrhea. Is amenorrhea a type of abnormal uterine bleeding? We read AUB. So is amenorrhea included in AUB? Yes, it is also an abnormal bleeding. So if I can divide, I can say this is the central cause, this is a peripheral cause, ovary, and this is a uterine cause. Okay, so based on which level is involved, there are 3 classes. WHO said category 1 is hypogonadotropic hypogonadism. So gonadotrop means if there is problem in hypothalamus or pituitary, what will happen? The gonadotropins will not be secreted. There will be problem in secretion of gonadotropins. As a result, ovary will not function properly. So it means my ovary was right, it was okay, it had no problem. Basically problem was gonadotropins. So as a result, because of gonadotropins, ovary stopped working. So when ovary stops working, then what will happen? Whenever ovary stops working, it has 2 functions, estrogen and the ovarian follicles. Okay, the ovulation, it has 2 functions. So when ovary stops working, there is no estrogen, there is no ovulation. We call it hypogonadism. Means the gonads are not functioning. You have to be very clear, this hypogonadism is not anovulation. Anovulation kya tha? That HPO axis is somehow disturbed, as a result ovulation is not happening. But ovary is functioning, estrogen is functioning normally, your gonadotropins are functioning normally. But because of some endocrinal disorder that we read, like PCOD or thyroid, the HPO axis functionality got disturbed. HPO axis has to function in a very regularized manner. GnRH has to be secreted in a very pulsatile manner. Now, if that pulsatility is affected, somehow, as we have read in physiology, GnRH is secreted in a pulsatile manner. Anything can affect that pulsatility. When that pulsatility is affected, only the ovulation is inhibited. So that condition is not hypogonadism. Your gonads are functioning. The patient has estrogen in her body. She will have secondary sexual characters. Because of anovulation, she will either have hypomenorrhea or, as we read in AUB, she will have prolonged amenorrhea followed by heavy flow. When I am talking about hypogonadism, means the severity is so bad the gonads are not working. Okay, when the gonads are not working, patient will not have estrogen, patient will not have ovulation. So, patient will neither have menses, patient will neither have secondary sexual characters. So, this is a severe condition. It is not an ovulation. So, whenever I am saying hypogonadism, means the estrogen in body is lacking. Okay, so hypogonadism can be because of a central cause, that the gonadotropins were not working, that is why ovary stopped working. We call it category 1, hypogonadotropic hypogonadism. What is category 3? First come to category 3. Category 3 is center was working fine, ovary stopped working on itself. Why? We will discuss. Ovary failed. When ovary fail, again ovulation and estrogen both are gone. Is it a hypogonadism? Yes, but we call it hypergonadotropic. Since center was working fine, ovary ne kya kiya? Ovary is producing very less estrogen. So there is no negative inhibition. Hypothalamus and pituitary will start secreting more FSH. They are trying to push ovary. They are trying to increase their FSH secretion so that ovary should start working. They don't know that ovary has failed. So as a result, whenever ovary fails, FSH level is high. So whenever ovary fails, it is always hypergonadotropic hypogonadism. Whenever problem is in hypothalamus or pituitary, it is hypogonadotropic hypogonadism. Is this clear? Group 2 is normogonadotropic. Means there is no problem with the gonadotropins. There is FSH, LH are normal. So hypothalamus pituitary has no problem. Then what is happening? It is just that, as I told you, the pulsatility is affected. As a result, anovulation is happening. Can you see? It is normogonadotropic anovulation. If your hormones are normal, your estrogen is normal, FSH, LH is normal, you never use the term hypogonadism. So, group 2 is normogonadotropic anovulation. Where comes the causes? PCOS, hypothyroidism, anovulation causes. So, group 1 is hypogonadotropic hypogonadism. They will mainly present with primary amenorrhea. If a patient, so this much is clear to us. Okay, now let's rub it off. So category 1 was hypogonadism because of a central problem. Category 3 was again hypogonadism because of a ovarian problem. Category 2 is basically anovulation. Okay, normogonadotropic means gonadotropins are normal. Gonadotropins are normal, ovaries function normal, means estrogen is also normal. Just because of problem in pulsatility of GnRH, anovulation is happening. Okay, so primary amenorrhea can be because of an ovarian cause and can be because of an hypothalamic cause. Primary amenorrhea can be because of proper anovulation, anything which is just affecting the pulsatility. So yes, anything which will affect the GnRH pulsatility will definitely cause anovulation, but it will not cause primary amenorrhea. A woman who has not attained menses ever, majority of time it presents as secondary amenorrhea. In fact, it is the most common cause of secondary amenorrhea, anovulation. A woman who was menstruating previously, who was ovulating previously, due to some endocrinal problem, she is not ovulating now. So this is the scenario how anovulation present. Okay, because it is a generally acquired cause. So whenever it is an acquired cause, it will cause secondary amenorrhea. Primary amenorrhea means a girl never attained menses. If the secondary sexual characters are absent, means she was never even exposed to estrogen. So it cannot be a secondary cause. It has to be something present since birth, some congenital cause. Then it is either hypogonadism because of central cause or hypogonadism because of ovarian cause. Anovulation can cause primary amenorrhea, but we will not discuss it here because it is a very rare cause of primary amenorrhea. Primary amenorrhea means a girl never attained menses is generally not because of anovulation. Anovulation is a very common cause of secondary amenorrhea. So we will discuss this cause and this cause. Okay. WHO has also included a group 4. Group 4, practically it is not used. They said prolactin disorders, hyperprolactinemia is group 4. They said ki we don't know where to put it. As such, this is a central cause, but still they have made it a group 4. So this much is clear. Whenever I will say hypergonadotropic hypogonadism, I will be talking about ovary. Whenever I will be saying hypogonadotropic hypogonadism, you will know that I am talking about some problem in the center, hypothalamus or pituitary. You know when I will be saying anovulation, you know I will be saying about something about secondary amenorrhea, not primary. Okay? This is clear. So let's begin with primary amenorrhea now. So I told you 4 structurally and functionally different compartments we need. In center we need hypothalamus pituitary. In the gonads we need ovary, and in the outflow tract we need uterus and vagina. All of them have to work. All of them should work together properly so that menses can happen. Now, what we have already discussed, that when the center is not working, we are getting hypogonadotropic hypogonadism. So hypogonadism means her estrogen is low, isn't it? Her estrogen is low. So if her hypogonadism means gonad is not working. Okay, there is some problem since the very start in the center, gonads are not working. So her estrogen is very low. Estrogen is the main hormone responsible for secondary sexual characters, the breast development. Will she have secondary sexual characters? No. In her, secondary sexual characters will be absent. If the problem is in ovary, we have seen, we will call it hypergonadotropin because gonadotropin levels will increase because negative feedback is not there. So we call it hypergonadotropic hypogonadism. It is also a hypogonadism. So hypogonadism, estrogen is not there in her body. Will she have secondary sexual characters? No. Here also secondary sexual characters are absent. Talk about outflow tract. Outflow tract has a problem. It means gonadotropins are normal. It means estrogen is normal. Just the problem is something in the uterus and vagina. So, if her estrogen is normal, will she have secondary sexual characters? Yes. And that is how the whole basis of evaluation is based. Secondary sexual characters are present. Now imagine a scenario. Question gives me a girl of 15 years, no menses, secondary sexual characters present. Secondary sexual characters present. I'll start thinking, secondary sexual characters are present. She has estrogen in her body. It means her hypothalamus pituitary functioning properly. It means her ovary are functioning properly. It means the lesion lies somewhere in the uterus and vagina. Question gives me, so what will be my next test? Ultrasound. That's only way of seeing the uterus vagina. If the question gives me 14-year-old girls, absent menses, no secondary sexual characters. Now I am thinking, secondary sexual characters are not there. It means she has no estrogen in her body. The source of estrogen is ovary. Either problem is in the ovary or the problem is in the center. Okay, so that is how your evaluations start. So the first step when a patient of primary amenorrhea comes to you is seeing the secondary sexual characters. So got it? So this is the first understanding about primary amenorrhea. What? That if a girl comes to me, if the question gives me primary amenorrhea, straight away look at the secondary sexual characters because that will tell us where the lesion is lying. Okay, among these compartments, where am I talking about? Where the pathology is? Let's start with the center first. So amenorrhea with no secondary sexual characters. That has to be very clear. If the center, the hypothalamus and pituitary are not working even before she attained puberty, we are talking about primary amenorrhea. So she has not attained puberty. So if there is a pathology even before puberty, then estrogen is low. Because estrogen is low, she will not have secondary sexual characters. Okay. So amenorrhea with no secondary sexual characters, cause being hypogonadotropic hypogonadism. So hypogonadotropic means gonadotropin levels are low. It means problem is in hypothalamus or pituitary. So let's discuss the most common cause. The most common cause of hypogonadotropic hypogonadism is physiological delay. So it is actually not a problem, but the thing is, the person is physiologically made like that. So in physiological delay, gonadotropin releasing hormone levels are very less. It is something in which you can also find a family history. And as such, there is no other pathology you can find. Okay, so this is how physiological delay. So I can say it is a diagnosis of exclusion. A girl comes to me, I did FSH-LH levels, that is how I'll know gonadotropin levels, and I saw that they are very less. So I will not tell her, Arey, aapko, you have physiological delay. I have to exclude the other causes first. There is something in the center. There can be a tumor. How can I just avoid it? So first I will evaluate her for other central causes. If there is nothing, then I'll say it's a physiological cause. It will get corrected. But I will give her a hormone, because if I don't, she will attain menarche very late and it can cause a psychological issue in that person. So the most common cause comes physiological delay. Second most common cause of hypogonadotropic hypogonadism is Kallmann syndrome. So what is Kallmann syndrome? Basically there is defective neural migration. So hypothalamic neurons, hypothalamus mein kya hai? It is just a neuronal structure, lot of nerves are there, they are the ones secreting the hormones. So these neural migration happen from olfactory placodes. Initially in embryo, they lie in the olfactory placodes, from there they migrate to the hypothalamus. When there is defective migration, what happens? These neurons do not function properly. Okay, and hence the gonadotropin levels is very less. Now where they are migrating from? From the, sorry, not the neural, nasal placodes. From there migrating from nasal placodes. So as a result, there is problem in the nasal nerves also. So patient will typically have amenorrhea, no doubt, low FSH-LH and anosmia. Inability to smell. So if question gives you amenorrhea with anosmia, it's a hypothalamic problem, Kallmann syndrome. Okay. Now other common causes which you are more worried of, that is the CNS tumor or a trauma or an inflammatory process, means a cyst sitting there. Okay, so you are worried of that. So how first you will take history. So of any trauma, of any CNS lesions can be very well evaluated by history. You will take history of any trauma. You will ask ki bhai, you have any convulsions? Because if anything is sitting there, patient might have convulsions. Patient have problem in vision. Patient can have constant headache. So this is all you will take in history. Even if nothing is there, you will still do gadolinium enhanced MRI. Okay, because you want to see ki koi center mein, I don't want to miss any lesion, I don't want to miss any tumor, right? So if everything comes normal, she does not have anosmia, now you say, yaar, it is a physiological delay. So physiological delay will have low gonadotropin, there might be a family history, there will be no pathology, all the pathology will be absent. One thing is, the bone age is also delayed in physiological delay. So bone age is also delayed. So as such, the patient is not delayed. As per age, you might see ki pubertal delay hai, but if you compare with the bone age, person will be on time. So bone age will be delayed. Okay? Last is functional GnRH deficiency. Do not confuse it with the constitutional delay. Constitutional delay means, or the physiological delay means, the person is genetically made like that, it has been running in family. Functional means there is some functional cause like malabsorption, malnutrition, stress, and basically you can, by the causes you can know that why all this will happen at a very early age. If these are present, they will obviously be more commonly be cause of secondary amenorrhea. At 13 years, the patient will not have stress or the significant malabsorption. These are the causes which will eventually develop later. So if you are talking about primary amenorrhea, something which is the patient has not even attained menses and secondary sexual characters, it has to be something genetic, like some tumor is there, it has some Kallmann syndrome, or is a physiological delay. What is the most common cause of hypogonadotropic hypogonadism? Physiological delay. Second most common cause, Kallmann syndrome. Clear? Okay. So let's revise what all we have read up till now. We have read that, see, what is primary amenorrhea? We read the definition. It is 13 years without secondary sexual characters, 15 years with secondary sexual characters. Okay. Then we read, there are 3 different departments. One can be hypogonadotropic hypogonadism. Patient will always have secondary sexual characters absent. Then the problem is somewhere in the center. If it is hypergonadotropic hypogonadism, problem is in ovary, FSH-LH will be high, here FSH-LH will be low. Up tak we have just read the hypogonadotropic hypogonadism. We read the most common cause is physiological delay and second most common is Kallmann syndrome. Okay, so this much is clear. Now let's solve some questions. Investigation for a primary amenorrhea in a girl with full development of secondary sexual characters should be performed by what age? So very clearly read again. They said with full development of secondary sexual characters. So secondary sexual characters, once they come, you wait for another few more years. You wait ki bhi estrogen is there in your body, maybe menses will come. So obviously the later wala age group will be selected. So which is 15 years. Okay. So central cause we have discussed. Now suppose center is functioning normally. Problem is in the ovary. So if the ovary has failed, and we will see why ovary will fail at such an early age of 13 years. Okay, ovary can fail at even 30 years ovary can fail. But then it will not cause primary amenorrhea. It will be secondary amenorrhea. A woman who used to menstruate, now she is not menstruating. So why ovary fails so early? We'll see the causes. But how the patient will present? Since ovary is not working, estrogen will not be there. So there is no negative inhibition in the center. As a result, the FSH-LH will be very high. So whenever FSH-LH are high, do not think of anything else. It is the ovarian cause. Do not start thinking that FSH-LH high hai. Is there a central cause which can present like this? No. Even if it exists, question is not trying to ask you that. So FSH-LH are high, always the cause is ovarian. Okay? So amenorrhea with no secondary sexual characters. So obviously again it will be amenorrhea with no secondary sexual characters. Secondary sexual characters need a hormone called as estrogen. If you do not have estrogen, you will not have secondary sexual characters. Okay? Now hypergonadotropic hypogonadism, the most common cause is gonadal dysgenesis. Dysgenesis, what does it mean? Something which has not formed properly. It is not failure. Failure means something was functioning and now it has failed. It is different from failure. Dysgenesis means it has not formed properly. Okay? And primary ovarian failure means it was formed properly but now it has failed. Okay? So the most common cause of hypergonadotropic hypogonadism is gonadal dysgenesis. It has not formed properly. So how do you describe gonadal dysgenesis? Whenever question will give you gonadal dysgenesis, they will mention streak gonads. So this is how a normal gonads will look like in a normal girl. See, can you see the blue color follicles are also there? So this is a normal ovary. They are pea-sized little globular. Streak gonads, can you see? You cannot even demarcate this ovary. You cannot even clearly demarcate. See, this is the ovary. It is streak gonad. It is not globular. It is like a streak. It is not functioning. Neither it is producing follicles, neither it is producing estrogen. So, clear presentation of streak gonads, we will call it. And most common cause of primary amenorrhea is gonadal dysgenesis. So, most common cause a girl comes to you with primary amenorrhea is gonadal dysgenesis. She will not also, since ovary is not working, how will she have secondary sexual characters? She will not have. Okay. What is the most common cause of gonadal dysgenesis? With gonadal dysgenesis, why is it happening? Obviously, there is problem in the sex chromosome. So, it is basically a genetic problem, a chromosomal problem. The most common chromosomal problem causing gonadal dysgenesis is Turner syndrome. Turner syndrome is the most common problem. Okay. Now, besides Turner syndrome, are there other problems? Yes. One is pure gonadal dysgenesis. Pure gonadal dysgenesis किसे कहते हैं? Means your chromosomes were normal, either XX or XY. They were normal. There were certain aberrations which you cannot diagnose. There is no technology right down to diagnose them, like ring-shaped chromosomes, or there are partial deletion, long arm deletion. So these minor aberrations in chromosome can very well lead to dysgenesis. Since the number is absolutely normal, we call it pure gonadal dysgenesis. So most common cause of gonadal dysgenesis is Turner syndrome. So can I say that Turner syndrome is the most common cause of primary amenorrhea? Absolutely. Another common causes are gonadal dysgenesis, XX or XY. Okay. Third is the rare enzyme deficiencies. Up till now, we were not focusing on them too much, but the questions have been asked in past 2 years on these rare enzyme deficiencies. So So first I just want to discuss how the patient of gonadal dysgenesis will present. Since it is the most common cause, we have to know. A girl or maybe a boy, XX or XY, gonadal dysgenesis has happened, or even take X0, whatever it is. Whenever there is dysgenesis, means your gonads are not working fine. What will happen? So there will be no estrogen secreted, absent. If it is XY, testis is not working. So what is the function of testis? Testis secrete two hormones, androgens, it is also not being secreted, and anti-Mullerian hormone. So no hormone is being secreted. By default, the formation of uterus and vagina needs no hormone. They just need absence of anti-Mullerian hormone. So if your body has no hormone, estrogen, androgen, kuch bhi nahi hai, it doesn't matter. Anti-Mullerian hormone is absent, the internal genitalia will always be uterus and vagina. What about external genitalia? External genitalia also do not need estrogen. Okay, male external genitalia need androgen, true. But external genitalia development for a female needs no hormone. So if it is an XY boy, but the testes have not working, there is no anti-Mullerian hormone, there is no androgen, internal genitalia will be by default female. External genitalia will be by default female. So they will look like female, be it XY, XX or X0. They will all internally and externally be female. They will not have what? They will not have secondary sexual characters. They will not have menses. But uterus and vagina are there. Okay, because uterus and vagina and external genitalia do not need any hormone. So in boys, why the uterus and vagina do not form? Because they have anti-Mullerian hormone. In boys, why the external genitalia is like that of a male? Because they have high amount of androgens. Since in XY gonadal dysgenesis, they both are not there, a boy will completely look like female, inside and outside. You will know only when the patient will have no menses. Okay, so this is how a hypergonadotropic hypogonadism patient present. Okay. So specifically talking about Turner syndrome. Turner syndrome may as such normal ovarian development starts in utero. When the baby is in utero, the development of ovary is normal. But suddenly high atresia starts happening. Accelerated atresia of follicles happen. Follicles start getting atresia very rapidly. And by the time the baby is born, the follicles are completely absent. Okay, since the follicles are absent, there is no estrogen. They are the source of estrogen, right? So no estrogen and hence there is no secondary sexual characters. Will the patient have uterus vagina? Yes. Will the patient have external genitalia like that of female? Yes. There are certain other stigmata which are associated with Turner, which you have to remember. You will be given these stigmata which you have to judge what it is. And in FMG, the question was asked, which of these stigmata are not present in Turner? Okay. So starting from head, there will be first, they are all generally short height. So they have generally short height. Then, so I have written, sorry, short stature, webbed neck, low hairline. So continue, niche jate jao. High arched palate, shield chest means nipples are wide apart. Increased carrying angle. What is carrying angle? Carrying angle kya hota hai? So it is the angle between your arm and your forearm. Why we call it carrying angle? Because God gave us this angle so that when you are carrying something like a bucket in your hand, if it is not at that angle, you are holding like this, if this angle is not there, your bucket will keep on striking your body. You will never be able to walk. That is why this angle was given to us, so that you can carry something and walk. That is why we call it carrying angle. Now this is exaggerated, means this is deviated more towards the lateral side. So this is increased carrying angle. Okay, increased carrying angle is there. Short fourth metacarpal and multiple nevi. These are the features of Turner syndrome. Okay. Besides all that, what is there? 5% of Turner syndrome have Y chromosome. It means they are mosaic, X0, XY. So 5% of Turners will have Y chromosome. Are you worried about it? Absolutely. Whenever there is Y chromosome, the gonadal tissue will always have some kind of testis-like structure. Minimal, but they will have. And whenever this testicular structure is lying in abdomen, why will it lie in abdomen? There is no scrotum. There is no external genitalia of male. It will lie in abdomen or in the inguinal area. Right? So anybody with Y chromosome, with gonads in abdomen or inguinal area, very high risk because of the higher temperature, very high risk of formation of gonadoblastoma. And gonadoblastoma is benign. Why I am worried? Because it can turn to malignant dysgerminoma. So when a question gives me that a patient comes to you, 14 years, primary amenorrhea, she has shield chest, increased carrying angle, what to do next? Don't think कि karyotype क्यों करना है? Why will I do karyotype? We know it's Turner. You will do karyotype. 5% Turners are mosaic with Y chromosome. And if there is Y chromosome, you have to do gonadectomy. You cannot leave gonads in abdomen and inguinal area. Suppose Y chromosome is not there, it's okay, it is safe. It will not turn into gonadoblastoma. Clear? So Y cell line should always be excluded. Besides that, there are other systemic abnormalities in Turner syndrome. How I used to remember? So there can be problem in the thyroid. So I can say thyroiditis. So from thyroiditis, I will remember basically it is autoimmune. And there will be also chances of diabetes. For R, remember renal anomalies, horseshoe kidney, right? That can happen. Then for U, so U ko ulta kar dete hain, so it is something like aorta. So there will be cardiac anomalies. Cardiac anomalies like coarctation of aorta, mitral valve prolapse. Okay, these are the problems that can happen in a Turner syndrome patient. Then NER, some neural problem in the ear. So sensory neural hearing loss. This is the problem. Are the Turner syndrome patient mentally retarded? No. Their IQ may be little low. They do not fall in category of mental retardation. What can happen in Turner is ADHD. So remember, this is also a PYQ. What all can happen in Turner? There is autoimmune problem leading to thyroiditis and diabetes. There can be, remember U, aorta, coarctation of aorta, cardiac anomalies, mitral valve prolapse. I'll do an echo. There can be R, renal anomalies. So I'll do an IVB, intravenous pyelography. NHL means some neural hearing loss. So there is sensory neural hearing loss. Also, the patient are not mentally retarded, but yes, ADHD is there, can happen in Turner. Is this clear? So if I summarize, अभी हमने क्या पढ़ा है? We have read अभी hypergonadotropic hypogonadism. Which is very commonly asked. The patient of all the hypergonadotropic hypogonadism always think of the failure of ovary. Ovary is not working, then only FSH are high. So ovary will not work if you are X0, if you are XX or XY with some gonadal dysgenesis. All present same. You can only differentiate them based on karyotype. Internally, all of them have uterus vagina. Why? None of them has anti-Mullerian hormone. So by default, they will have uterus vagina. Externally, for male genitalia formation, you need high androgen. Okay, that is not there. So externally, everyone is female, and secondary sexual characters in absent in all. So as soon as I get a patient of primary amenorrhea with absent secondary sexual characters, I know cause can be central or ovarian. What do? I do gonadotropin levels. Hypergonadotropic hypogonadism, I know the cause is in ovary. But what is the cause? How will I differentiate? Only thing I can do is karyotype. Karyotype will tell me what is there. Okay? And why it is necessary for karyotype? Because see, XY gonadal dysgenesis. And what did I told you? Whenever there is Y, this patient does not have scrotum or external genitalia male. So this patient has testis, non-functional testis. I agree. But where are they lying? They are lying in abdomen or inguinal area. Will this patient need gonadectomy? Absolutely. So this patient will need gonadectomy immediately, otherwise it will turn into cancer. Turner, in case it has also mosaic Y, then it will also need gonadectomy. That's why I am doing karyotype. Right? So am I clear up till this that hypergonadotropic hypogonadism means ovarian failure? Is this clear? But no, it is not just ovary. One rare enzyme deficiencies are the one which will cause ovary are functioning normally, ovary function normally, but still patient has hypergonadotropic hypogonadism. Rare enzyme deficiency. So rare enzyme deficiency, up till now we were not teaching them, but since the questions have been asked again, time and again, they are rare as by the name, but they are cause of hypergonadotropic hypogonadism. it means the patient will present with absent secondary sexual characters, yes. But it is hypergonadotropic means FSH are high, yes. But ovary is functioning normally, yes. Okay, so what is that enzyme? It is 17-alpha hydroxylase deficiency. What is it doing? 17-alpha hydroxylase. See, this is a very scary chart, I know, of androgen and steroid synthesis. So here is the 17-alpha hydroxylase. Can you see here? This is 17-alpha hydroxylase. When this enzyme is deficient, what is happening? Lot of aldosterone is being secreted. So obviously, patient will have hypertension. But there is no cortisol and there is no androgen. Beat any androgen, beat testosterone. If it's XY, gonads are functioning normally, remember. So testosterone will not be there. Gonads are functioning. If it is XX, ovary is functioning, but testosterone se hi estrogen banta hai. Estrogen is actually formed from testosterone only. So that will also not form. So any androgen is, any steroid is not there in the body. So what the patient will present? Obviously hypertension. It will be, if it is XX, the ovaries are functioning properly. But the body does not have estrogen. Why? Because this steroidogenic pathway in the ovary is not happening. So this pathway is happening in the adrenal gland and in the ovaries, everywhere. So since it is not functioning because of 17-hydroxylase deficiency, there is no estrogen. So inside, will there be uterus and vagina? Yes. Externally, will it be like a female? Yes. Will she have breast and will she have menses? No, because there is no estrogen. Let's talk about XY. XY, are the testes working properly? Yes. Will he have uterus vagina? No. Testis AMH secrete kar rahe na. Antimullerian hormone is functioning. So there will be no uterus and vagina. So this is the only cause of hypergonadotropic hypogonadism where uterus vagina are absent. अभी तक हमने जो भी causes पढ़े थे, whatever causes we read in hypergonadotropic hypogonadism, uterus vagina were present in everyone. So uterus vagina are absent. External genitalia, androgens नहीं है. There are no testosterone. So external genitalia will be female. That is why we are reading it in primary amenorrhea. What about secondary sexual characters? There is no estrogen. So there are no secondary sexual characters. But important is there is no uterus vagina. If I go back to this chart of mine where I said that this is hypergonadotropic hypogonadism, uterus vagina is present in everyone except the rare enzyme deficiency. Where if it is XX, it will present same. But if it is XY, it will have female this, it will have this, but uterus and vagina are absent. How the question will tell you uterus vagina absent? Question will always give you blind vaginal pouch. Whenever question says blind vaginal pouch means नीचे का जो sinus से बनता है, the lower 1/3 of vagina formed by sinovaginal bulbs. So that will be formed. But the upper vagina is not there. So whenever question is trying to say uterus vagina absent, they will say on examination, vagina ends up in a blind pouch. It means there is nothing up. This is the only cause. Has this been asked in question? Yes. So they asked a question. A girl came with primary amenorrhea, absent secondary sexual characters, and FSH-LH were high. On examination, uterus vagina were absent. So it was very confusing. FSH-LH are high, it is hypergonadotropic. How come uterus vagina are absent? By default, uterus vagina will be there. The answer was rare enzyme deficiency. Okay? Is this clear? Do not confuse it with congenital adrenal hyperplasia. Congenital adrenal hyperplasia is deficiency of 21, 11 and 3 here. Here, aldosterone is the problem, cortisol does not happen. All the byproduct go and form. All the byproducts will go and form the androgen. So congenital adrenal hyperplasia, jo we learn the 3 enzyme deficiencies, that is an hyperandrogenic disorder. There is hyperandrogen because all these byproducts will go and form excess androgens. We are reading 17-alpha hydroxylase. There are no steroids, neither androgen, neither estrogen. So that is how it's different. CAH, congenital adrenal hyperplasia, we will discuss in hyperandrogenic disorders. Hyperandrogenic disorders present with ambiguous genitalia. Anything, whenever there is some problem whenever the androgens are high but they are not able to act properly, like there is problem in receptor androgen insensitivity syndrome, or like there is aromatase deficiency. Aromatase deficiency में क्या होता है? The androgen which has to convert into estrogen, that is because of aromatase, that is not happening. Again, high androgen, congenital adrenal hyperplasia, they all are causes of ambiguous genitalia. A girl with ambiguous genitalia. So that we will read in ambiguous genitalia per se, those enzyme deficiencies. Abhi we are just dealing with a girl who look exactly like a girl, but she is just not having menses. Okay, so hormone problems and all these problems are a range. Congenital adrenal hyperplasia can range from ambiguous genitalia, but it can also present as a completely normal looking female with hyperandrogenic features. So there can be any presentation. Same with androgen insensitivity, it can cause ambiguous genitalia. If it is partial, if it is complete, it will completely look like female. So it's a range. Right? If the deficiency is partial, it will cause confusing genitalia, ambiguous. If deficiency is complete, it will call complete female looking genitalia. Okay, so we have read abhi tak hypergonadotropic hypogonadism. Forget this. We are not reading this right now. So what we have read gonadal dysgenesis. What was the most common cause of gonadal dysgenesis? We read it is Turner syndrome. Is gonadal dysgenesis most common cause of primary amenorrhea? Absolutely. Okay. Now comes the primary ovarian failure. It means ovary formed normally, it just failed in a very early age. Obviously, it is very rare. The severe damage can happen due to radiation or due to chemo. It is rare because basically it is age dependent. As you grow older, your ovary have less follicles. So radiation and chemo affect the older age women more. The chances of getting ovaries failed are higher in a older age woman because follicles are very less, and whatever dividing cells are there, the follicles, they will get destroyed. In a pubertal girl, there are a lot of follicles. Some might be destroyed. It will cause maybe transient amenorrhea, but eventually after 6 months, ovaries will resume their function. That is how the general present. Okay, so they are very rare causes. So since now we have read hypogonadotropic hypogonadism and hypergonadotropic, in both of them secondary sexual characters were absent. When I am saying hyper and hypo, what is the criteria? So when FSH level is less than 5, it is hypogonadotropic. Revise again, where the problem is in? Either it is in hypothalamus or it is in pituitary. How am I going to evaluate? Obviously, I will take history of central lesion, but will I not need MRI and CT scan? I will. FSH high, hypergonadotropic, problem somewhere in the ovary. So how will I know what problem is there? I have to do the karyotype. What about ma'am, rare enzyme deficiency? Yes, for that rare enzyme deficiency, you will need enzyme levels. Okay? So, we have read a lot. Let's quickly revise. Most common cause of primary amenorrhea, ovarian dysgenesis. Most common cause of ovarian dysgenesis, Turner syndrome. Turner syndrome associated with other anomalies? Yes, cardiovascular, renal, autoimmune and sensory neural hearing loss. How will you know? You will know by primary amenorrhea with absent secondary sexual characters with short stature. But the diagnostic is always karyotype. Okay. Then, so if there are physical stigmata, there is high FSH, and then you will do a karyotype which will make a diagnosis of Turner syndrome. Suppose there is high FSH, but there is normal karyotype, normal height. It is pure gonadal dysgenesis. So XX या XY, there is no problem in the chromosome number. It means pure gonadal dysgenesis. Okay. Then if suppose streak gonads नहीं है, high FSH है, normal karyotype है, but they are not streak gonads, they are normal gonads. What it is? It is rare enzyme deficiency. So these Turner and pure gonadal dysgenesis will have streak gonads. Gonads are not functioning, they have never formed properly. But if the gonads are not streak, it means it is the rare enzyme deficiency. Right? Again, how we discuss the patient will present? Hypergonadotropic hypogonadism, how the patient was presenting? Internally, uterus, vagina, all of them. Externally, female. Breast, absent. Menses, absent. Pubic and axillary hair, very important point. Pubic and axillary hair. If you remember our class of puberty, what is responsible for pubic axillary hair? Adrenal androgens. DHEA and DHEAS, adrenal androgens, which have to be secreted by adrenal glands. So pubic and axillary hair will be totally present. There is problem in the gonads, but the androgens are being secreted normally from adrenal glands. So pubic and axillary hair in gonadal dysgenesis, do not get confused. They are completely normal. Okay? Here we read one rare enzyme deficiency. I always laugh because it is so rare, then also it is asked in question. So this rare enzyme deficiency, if it is present in an XY individual, then that is the only exception where uterus vagina will be absent. But externally it will be female, breast will be absent, menses will be absent. Okay? And yes. Okay? So this is the only deficiency we read. Now let's solve some question. What are the classical FSH-LH levels in Turner syndrome? We know, we are discussing whenever ovaries fail, gonadotropins are high. So we will have high FSH and high LH. 16-year-old girl present with primary amenorrhea. She has female phenotype, height is 150, means normal. Poorly developed breast. On examination, vagina present. When they say vagina is completely present, it means upper uterus is also present. Ultrasound revealed normal uterus, but gonads were not detected. Why? It means they were streak. It showed high FSH expected and karyotype XY. It is leading you to the diagnosis. What is it? XY hai, under they have uterus vagina, it means gonads are not working. What is it? Is it gonadal dysgenesis, androgen insensitivity, Kalman syndrome or Turner mosaic? Turner mosaic will present similarly, but it will be X0. Kalman syndrome is a hypogonadotropic hypogonadism. So in that syndrome, so if there is Kalman syndrome, obviously, so Kalman syndrome is a hypogonadotropic. There is problem in the center. So if it's an XY boy, there is a problem in the center. Obviously, testes will not work properly. But testes are not failed, isn't it? Testes are secreting AMH still. So obviously, there will be no uterus and vagina in hypogonadotropic hypogonadism, isn't it? But yes, in that male also, the center, the hypothalamus pituitary are not working. It means testes will not function properly. So there will be decreased testosterone secretion. So how the patient will present? Patient will have normal outlook like that of a female, but he will be not a very good muscle development, not very good hair development. Means though it will be a male, but the proper male features will not be there, and mainly it will come to you with infertility. Right? Because gonads are still functioning. Though there is problem in the center, some little level of testosterone will be secreted and anti-Mullerian hormone will be secreted. So it will look like more of a male, but yes, as the puberty will shoot, that male type feature will not come. The patient will not be able to produce sperms also. Right? Androgen insensitivity is again XY male, but it is androgen insensitivity. It secretes that there is no problem in the testis. The end receptors are not sensitive to androgens. If the receptors are not sensitive to androgens, it means uterus vagina will be absent again. Why? Because AMH is being secreted. So uterus vagina will be absent. So the only diagnosis here is gonadal dysgenesis. Since I have said whenever FSH is high, there is problem in the gonads. Androgen insensitivity is the problem in the end receptor. So it is the gonadal dysgenesis. 15-year-old patient comes to OPD with absence secondary sexual characters. Again, as soon as they tell me absent secondary sexual characters, I am thinking ovary or the center, something is involved. You advised hormonal profile which showed estradiol is 10 picogram, which is very less. Normal estradiol should be at least more than 4 picogram per 40 picogram per ml. FSH is 6, LH is 7. So it is almost at the lower limit. We said less than 5 is normal, is low. So it is at the lower limit, and estradiol is less. So what will be your next line? Something in the center. CT scan, reassurance, karyotype, TSH. It can be very well a constitutional cause. But unless we rule out some central cause, how can we call it constitutional? So we have to first do a CT scan. If it is normal, then I will reassure. Karyotype will be done only if FSH, LH are high. If it is high, then my next test will be karyotype. TSHR prolactin cause the secondary amenorrhea, not the primary, because they are causes of what we read, anovulation. So we read center, we read ovary. We read कि दोनों में the hypogonadism is happening. We read since hypogonadism is happening, that is why in both of them the secondary sexual characters are absent. Now we come at the last, outflow tract. If the outflow tract has a problem, center and ovary are functioning normally, patient will always have secondary sexual characters present. So as soon as question gives you a girl of primary amenorrhea, secondary sexual characters present, chuck ovary, forget hypothalamus pituitary, focus on uterus and vagina, right? So girl with primary amenorrhea with secondary sexual characters present, what will you think of? Problem in uterus, vagina. Now problem could be first that outflow is the problem, that uterus, vagina are normal but they are not coming out. So what is menses? Menses is the visible bleeding, isn't it? That's what menses is. The visible blood discharge is menses. So when the bleeding is happening but it is not visible due to some obstruction, it is also amenorrhea. So either there is problem in the outflow or there is problem in the Mullerian structure. So uterus is formed by what? By Mullerian structures, right? Uterus, vagina are by Mullerian ducts. So if the Mullerian ducts have not formed the uterus properly, then hormone level will be normal but patient will not have menses. A very different cause we just read in the question was androgen insensitivity. Okay, we will see how androgen insensitivity will cause secondary sexual characters. Why I am including it in the last peripheral causes. So first discuss the outflow and Mullerian anomalies. Outflow problems कब हो सकती हैं? When there is blockage, okay, or the outflow tract is missing, or the uterus is not functioning. Outflow tract is missing means there is Mullerian agenesis, means uterus ही नहीं बना है, या फिर cervical agenesis, uterus बना था, bleeding हो रही है but there is no cervix. Non-functional uterus means curated discharge happened and as a result resulted in Asherman. Now you can remember, if the Asherman has happened means a girl has got herself curated. Why the curettage is done of uterus? Because of pregnancy. Obviously it will be a cause of secondary amenorrhea. A girl who had menses, she got pregnant because of tuberculosis or because of recurrent curettage, Asherman syndrome happened. So non-functional uterus is a very rare cause of primary amenorrhea. The common causes are blockage in outflow tract or outflow tract is missing. Okay, if we talk about blockage, so whenever blockage, question will give you what? Always will give you first of all. So primary amenorrhea, you might be bored up till now listening to the same terms again, but this is how it is. With secondary sexual characters present with cyclical pain. Why the pain is cyclical? There is something which is happening cyclically every month. What happens every month? Menses. Cyclical pain means her menses are happening, but it is not coming out. So she is having pain cyclically. It means the menses are happening. It is not coming out. Very clear indication of the blockage. Since the blockage is there, where the blood will collect? In the uterus, leading to hematometra. Eventually, it will collect even in the tube. And it will go out in the pelvis in forming endometriosis. So it can eventually, it is very painful. Eventually, it can lead to complete infertility if the blood is there whole in the pelvis. Right? So cyclical pain will be there. Patient question will give you on examination vaginal bulge, plus or minus. It does not need to be present always. Okay? Patient will give you abdominal lump. What is this abdominal lump? It is hematometra. It has become so enlarged, it comes in the abdomen. So this is how question will give you a scenario of blockage. So blockage can be because of many causes. Let's read the more common cause, imperforate hymen. So hymen is not a Mullerian structure. The lower one-third, lower one-third of vagina is formed by what? By urogenital sinus. And upper two-third is formed by Mullerian duct. So the junction is the hymen. So hymen is lying just near the orifice. So whenever there is blockage because of hymen, it will always be seen as a bulge. Since, can you see this image? Hymen is so close and such a thin membrane. The above collected blood will lead to bulging of it. So whenever something is bulging, it means it is very thin. Suppose it's a thick muscle. It's a thick muscle. Anything is collecting behind. It will not cause bulge, right? But if it's a thin membrane, very thin, something is collecting behind it, it will lead to bulging of that structure. So when question gives you a blue bulging membrane is there, it is not septum. Septum is muscular. It is imperforate hymen. And you can see it bulging because it is lying very close to the vaginal orifice. So it will be very well seen as a bulge. And in fact, when the patient does Valsalva, the bulge will increase. And why is it blue? Because it is thin. So the blood which is being collected behind it is seen as bluish tinge. Okay. So normal secondary sexual characters. At menarche, cyclical pain and acute urinary retention can happen. Why? Because it is, the whole vagina is filled with blood. Just ahead of vagina is lying urethra. The blood is filling the vagina, leading to urethral pressure. So patient can have urinary retention. Okay. And endometriosis. Okay. Question will give you a blue bulge seen in the vaginal orifice. What it is imperforate hymen. What will you do? As soon as it is diagnosed, you will give it a cruciate incision. You want to give it because otherwise it will lead to severe endometriosis. So as soon as it is diagnosed, you give it a cruciate, means something like this. This is a cruciate incision and you open the flaps. It is so thin membrane, you give the incision, it will open up, all the blood will drain. So this is how it presents and this is how it is treated. Okay. Another cause of blockage is transverse vaginal septum. It is less common. It is a septum in the vagina. It is a thick muscular septum. So basically vaginal plate which was supposed to get canalized, it has not get canalized, presenting as septum. Patient will have normal secondary sexual characters. Patient will have cyclical pain, perineal and abdominal, but it will not show a bulge like this. This was lying near the orifice and blood is making it bulge. Here, if you do PS, you see that vagina is very short, some septum is there. It is not bulging because it's thick muscle. And just locally you cannot see, you have to do PS. Generally, transverse vaginal septum are high. They can be high, they can be mid and they can be low. High vaginal septums are most common. So they are not visible just by local examination. You do PS, then you see the septum is there. Okay. Then investigation, you do ultrasound and MRI to see at what level the septum is. Right? What is the treatment? You cannot simply just cut it and the blood will drain. It's thick muscle. So it is not cutting it. It is basically excision with anastomosis. Whenever you are cutting muscle, you will be creating a big gap. So you have to anastomose the upper and lower segment. Right? So it's a little complicated procedure and that is why it is less common. Imperforate hymen thankfully is more common. So excision with anastomosis and maybe graft. If the septum was thick enough, you are removing the septum, you need to put a graft in there. That is the treatment. How we are differentiating it from imperforate hymen? Just by the local examination. That was a bluish bulge. That was a bluish bulge. It is a non-bulging pink membrane. Not even pink membrane, you can give pink structure. Right? Then now let's move on to the less common causes of blockage. Cervical agenesis. Cervix has not formed, so whole blood will collect only in the uterus. Will the vagina also have blood? No. So will it cause urethral compression? No, because vagina, if the blood is in uterus and the cervix has not even formed, how the blood will reach vagina? So vagina has no blood. Vagina is completely normal. You see a block here, up high up, because there is no cervix. So blood is all over in the uterus. Again, cryptomenorrhea, normal secondary sexual characters, short vagina and cervix is not visible. That's what you see. I cannot see the cervix. I can see vagina, not the cervix. Diagnosis is via MRI. How will you do? Now, regenerating cervix is very, very difficult. So, though they say uterocervical anastomosis, it cannot be done. Uterus and cervical anastomosis. The main treatment is remove the uterus. Why? She will keep on bleeding, she will keep on having pain, she will have endometriosis and a complicated pelvis. So, it's better to do hysterectomy in cervical agenesis. Right? So, if the question comes to me, how to differentiate? First of all, whenever the question is giving me primary amenorrhea, then question is giving me secondary sexual characters present, then I am thinking about some problem in uterus and vagina. Now they said uterus present. Uterus present hai. Bleeding is not coming out. Secondary sexual characters present, it means there is no problem in ovary and hypothalamus. It means there might be some blockage. So, imperforate hymen is more common compared to TVS. It is a thin blue bulging membrane. It is a non-bulging pink tissue. Associated urinary obstruction will be there. Why? Because whole vagina is filled with blood. Whereas transverse vaginal septum, yes, they can present with the vaginal complication if the septum is low down. But the more common is higher vaginal septum. Obviously, if the bladder is there ahead and urethra is here, it will not get compressed. Okay, no vaginal orifice because imperforate hymen is lying just at the orifice. Here, vaginal orifice is visible. But yes, depending on where the septum is, the vagina can be small and long. Okay? Now, one question was asked. The question was asked again. Primary amenorrhea, secondary sexual characters present cyclical pain. On PR, vagina was full. That was the question. And the options were imperforate hymen. Options were cervical agenesis. It's a recent question. Transverse vaginal septum or vaginal agenesis. Vagina is full. First of all, cryptomenorrhea, vagina is on PR is full. Full with what? What are they trying to say? It is filled with blood, obviously. So, in which of these pathology, they all are obstructive. Vagina will be filled with blood. In which of them? In cervical agenesis, this is uterus. In cervical agenesis, will the vagina be filled with blood? Will vagina be full in PR? No. There is no blood in the vagina. In vaginal agenesis, vagina is not formed. Will it be filled with blood? No. Vagina is not formed even. In transverse vaginal septum, in low vaginal septum, yes. But most cases I have told you again and again, it is higher vaginal septum. Again, vagina is not filled with blood. Only condition where vagina is filled with blood is imperforate hymen. So, this was the answer. Okay. So, top points, what do we have to remember? Primary amenorrhea with normal secondary sexual characters, outflow problem. Obstruction it can be TVS, imperforate hymen or cervical agenesis. Symptoms will be of cryptomenorrhea. Crypto means chupa hua, hidden. So, that is what cryptomenorrhea. Menses are happening but they are hidden somewhere. Right? Okay. That we have seen. How do we differentiate? Clear? Should we move ahead? Let's solve some questions now. A 16-year-old girl presents to OPD with primary amenorrhea, cyclical pain. Clear? Hai? Okay. Perineal examination revealed bulge protruding from vagina. Anything that can protrude from vagina is very thin. What are we talking about? Transverse vaginal septum, complete atresia, imperforate hymen, cervical agenesis. Hymen. Nothing else will bulge. Patient comes to OPD with complaint of primary amenorrhea. She has well-developed secondary sexual characters. As they give you this, start thinking where the lesion is lying. There is no positive family history or detectable functional cause. How will you follow her? Now tell me. She has secondary sexual characters present. How will you follow her? Where is the problem lying if the secondary sexual characters are present? In uterus vagina. Either you locally examine. If they are asking you the investigations, what will help you seeing uterus vagina? Ultrasound pelvis. So, if primary amenorrhea is there with no secondary sexual characters, the problem is in center or ovary. How will I know where the problem is? We call it either hypergonadotropic or hypogonadotropic. So, obviously, I will do gonadotropins level. If it is hyper, we have read the definition, more than 20. If it is hypo, means less than 5. If it is hyper, what I am dealing with? Ovary. What will I do? It means ovary is not functioning. Obvious. Why is ovary not functioning? What will I do next? I will get karyotype. If hypo hai, what will I do next? Some problem in the center. I'll do CT or MRI. Right? Primary amenorrhea with secondary sexual characters. What will be my next step? Ultrasound. Clear? Okay. A 17-year-old female, cut. On. A 17-year-old female complained that she has not started menstruating. There is no history of weight loss or excess exercise. Each of her sisters achieved menarche on time. No significant history. On detailed question, mother tells you that her daughter is missing right kidney. Okay. On examination, she is tall, weight 58, that's normal, blood pressure is normal. She has Tanner stage 4 breast. So in puberty chapter, we have read the Tanner staging. So Tanner 4 means fully developed breast. Okay. Pubic and axillary hair are also present. What will be the diagnosis? So this is the next pathology. Okay. So they have given us Tanner stage 4 breast. It means the secondary sexual characters are present. So I'm looking something in the uterus vagina. So pubic axillary hair are present. It means adrenal androgens are working fine. They have given one thing, missing right kidney. So what it is? So is it a transverse vaginal septum? They have nothing given about cryptomenorrhea. Okay, there is something in the problem in the periphery only. Polycystic ovarian syndrome will not present with primary amenorrhea. It is the most common cause of secondary amenorrhea. A patient who was menstruating, she might have got pregnant also. Then in later life, because of PCOS, she stopped menstruating because of anovulation. Okay, so it is presenting secondary amenorrhea. Kallmann syndrome is a central cause. Okay, whenever it's a central cause, Kallmann syndrome, will she have secondary sexual characters? No. So it is something Mullerian agenesis or septum. We have not read Mullerian agenesis. Now let's read. So in outflow, we talked about either there is obstruction or there can be missing tract. It is not there. So outflow tract missing means uterus vagina missing is MRKH. It is Mullerian agenesis. So it is also called as Mayer-Rokitansky-Kuster-Hauser syndrome. It is the second most common cause of primary amenorrhea. What was the first most common cause? Gonadal dysgenesis. In gonadal dysgenesis, what was the most common cause? Turner syndrome. So most common cause of primary amenorrhea, Turner syndrome. Second most common cause of primary amenorrhea, MRKH. How the patient will present? Patient is normal, 46XX. Her ovaries and hypothalamus are functioning fine. It means her secondary sexual characters are well developed. But somehow the Mullerian ducts have not formed the uterus. So that is why, will she have cryptomenorrhea? No, she is not having menses. She will just not have any menses. So secondary sexual characters are present. Pubic axillary hair is a function of adrenal androgens. That is also present. It's just that she is having no menses because of agenesis of genital tract. Important, MRKH is very well associated with renal anomalies and spinal anomalies. So question can many times give you this. You should always, you should also know that whenever you have diagnosed a patient with MRKH, you evaluate by doing a renogram because of very frequent presence of horseshoe kidney and by spinal X-ray, because these two are a common association of MRKH. Okay. So this is a cause how the patient is presenting, like in this question. They said breast hai, axillary pubic hair hai, but missing right kidney. So there is problem in the Mullerian development. It is Mullerian agenesis. Right. Absence functioning endometrium, very rare finding. Functioning endometrium absent generally happens due to some procedure, due to some infection. So that will happen in a later age. A patient who gets pregnant, gets curated, she will only have no non-functional endometrium. So generally presents with secondary amenorrhea. Rarely though anything can happen. Rarely it can be cause of primary amenorrhea also. Okay, if it does cause primary amenorrhea, physical examination will be normal, internal tract will be normal, karyotype will be normal. Right? So let's cover this chart. In this chart, अब तक ये था हमारा hypergonadotropic hypogonadism, where we read that this is normal, uterus vagina sub में है, it is externally female, secondary sexual characters absent. Now we come to MRKH, which is the problem of the genital tract. So inside there is no uterus vagina. Outside she is a female because it is XX. But secondary sexual characters are present because uterus vagina is not there but ovary is functioning. So this is how you differentiate based on scenario. No uterus vagina, secondary sexual characters present, MRKH or maybe obstruction. Okay. So how to differentiate it from obstruction? Obviously there will be no cryptomenorrhea. So there will be no cryptomenorrhea. That is how we will know it is not even obstruction. Okay. So what we read, amenorrhea with secondary sexual characters, either problem in the outflow means there is obstruction or Mullerian anomalies, yani ki MRKH. We forgot one thing, androgen insensitivity. Now this is a problem where primary amenorrhea is there but secondary sexual characters are present. Let's see what is androgen insensitivity. These are nothing but these are XY individuals. It's not a girl, it is androgen insensitivity. Who has androgens? XY boys. But testis is functioning normally. As a result, there is a problem in the sensitivity. The end receptors are not sensitive to androgens. As a result, because of this receptor problem, their external genitalia. So, male external genitalia need androgen hormones. Hormone is normal, but receptor is not sensitive. So, as a result, they look like female externally. But why are we reading it in problem of genital tract? Because here, just like MRKH, uterus, vagina are absent. Why? Why, you tell me, why uterus, vagina are absent? Testis function. So, we have androgens and we have another hormone, anti-Mullerian hormone. It is functioning. This hormone has no receptor problem. So, it will not let uterus and vagina form. Uterus and vagina will not form. So, it means inside they will have a male type of genitalia? No. Because male internal genitalia need androgens. So, in males, that is the problem. Even external genitalia needs androgen, even the internal genitalia needs androgen. Since androgen, everything is insensitive to androgen, their internal genitalia will be not even male. So, they will not have any internal genitalia. Just like MRKH, nothing. Absent. Externally, they will look like female. Because looking like female needs no hormone. But looking like male needs androgen. Since the receptor is not working, it will look like female. One catch here is pubic and axillary hair. Pubic and axillary hair, I have told you, is a function of what? Adrenal androgens. Since adrenal androgens are being secreted, but again, there is receptor defect, pubic and axillary hair are absent. It is exactly presenting like MRKH, isn't it? A girl with secondary sexual characters. Here secondary sexual characters, where from it will come? Since the androgen level is high, all the androgen will go into the periphery and will be converted to estrone. Again, even in the center, the pituitary is androgen insensitive. Everywhere it is androgen insensitivity. So, there will be no negative inhibition. As a result, androgen levels will be high. This high androgen will produce so much estrone that the breast development will be there. Though the breasts are not fully developed, but it is there. Means the areola is not fully developed, the Montgomery tubercles are not there. So, final fully matured breast is not there, but yes, they are up till Tanner 3. Okay. So, breast development is present due to high estrone. So, a girl with secondary sexual characters, you did ultrasound, uterus vagina is absent. It can be MRKH, it can be an XY boy with androgen insensitivity. What the question will give you to differentiate? How will you differentiate between an MRKH girl and an androgen insensitivity boy? So, MRKH is a girl XX, whereas androgen insensitivity is an XY boy. How will you differentiate between these two? So, testosterone first. Since it is XY, the testosterone is in a male range. It's in a male range. Whereas in this, the testosterone is very less. In females, testosterone is there, but it is very less in amount. Then, in both of them, uterus, vagina are absent. But here, pubic and axillary hair are absent. Here, pubic and axillary hair are present. That's how question will give you. Question will give you high androgen levels. It is androgen insensitivity. Question will give you pubic axillary hair absent. They are indicating AIS. Okay. What else? They can give you on examination, there is inguinal masses. Whenever question give you inguinal masses, you know what they are talking about? Gonads. Inguinal masses means gonads. And ovaries are never in inguinal area. They are always in abdomen. They are not palpable. So, whenever question gives you inguinal masses, means they are saying testis lying in the inguinal area. So, question can give you inguinal masses present. Think. Inguinal masses means question is telling me testis. Testis is there in androgen insensitivity. And last, the definitive method is karyotype, XX and XY. You do the karyotype and you clearly differentiate. So, that's how the question will tell you difference between these two. Okay. So, Testosterone is normal range in androgen insensitivity syndrome, right? There is blind vaginal pouch. Blind vaginal pouch, whenever is given, it means the vaginal pouch is small. Above that, there is nothing. It means there is no uterus vagina. So, blind vaginal pouch, absent pubic and axillary hair, breast developed, but areola is pale and nipples are immature. But yes, it is developed breast. Testis present in inguinal area or in labia. So, they will give you labial masses or inguinal masses. Inguinal masses are never ovary. Ovaries are never palpable. Usually tall with unicaudal tendency because it is XY, it's a boy. So that is how the question will give you different things. Question can give you that testosterone level, question can give you inguinal masses, question can give you pubic axillary hair, question can give you straight away the karyotype. Otherwise, they present very similarly. Now fit them again here in this table. So this was hypergonadotropic hypogonadism. This was MRKH, no uterus vagina, androgen insensitivity, no uterus vagina. Look like female, look like female. Secondary sexual characters present? Yes, here also breast present. But we know how to differentiate. Differentiate based on pubic and axillary hair. Differentiate based on presence of testis. Differentiate based on levels of testosterone. Differentiate based on karyotype. Clear? Is this clear? Okay. So, missing genital tracts. Whenever a girl presents to me with primary amenorrhea with secondary sexual characters present, I will be doing what? I will be either doing a local examination or doing an ultrasound. In ultrasound, either I can find an obstruction, then the causes I know. Imperforate hymen, I have read transverse vaginal septum, we have read cervical agenesis. If they say uterus vagina absent. So there are only two causes where secondary sexual characters present and uterus vagina are absent. Because in gonadal dysgenesis, uterus vagina are present. So uterus vagina are absent are MRKH or androgen insensitivity. MRKH is the second most common cause of primary amenorrhea. And androgen insensitivity is the third most common cause. What is the first most common cause? Turner syndrome. Then secondary sexual characters are present in both of them, but MRKH has these features. It's XX, normal female testosterone associated with renal and spinal anomalies. AIS, XY, male level testosterone, absent pubic and axillary hair. One important जिस पे question आया है, if there is partial androgen insensitivity, it means some of the tissue is sensitive and some is not. How this patient will present? It means अभी तक देखो अगर it's complete insensitivity, so external genitalia is not at all sensitive to androgens, it will completely look like female. But if it is partially sensitive, then some development will be like male, some development will be like female. As a result, it is a cause of ambiguous genitalia. So ambiguous genitalia with pubic axillary hair absent is partial androgen insensitivity. So let's solve some questions now. A 16-year-old female with well-developed secondary sexual characters. Okay? So she has this well-developed characters. Ovary has gonads. So ovary has gonads, absent uterus vagina. So there is no obstruction. So absent uterus vagina, secondary sexual characters present. What am I thinking about? Either MRKH or AIS. But they have clearly given as ovary as gonads. Which of them have ovary? XX or XY? Obviously MRKH. So what am I talking about? Turner syndrome, Mullerian agenesis, transverse vaginal septum, testicular feminization syndrome. Mullerian agenesis. What is testicular feminization syndrome? Another name for androgen insensitivity syndrome. Means testes have got feminized just because there is insensitivity. So testicular feminization syndrome is another name for androgen insensitivity syndrome. One important point that partial androgen insensitivity syndrome is another name is Riefenstein syndrome. Common cause of ambiguous genitalia. Ambiguous genitalia, disorders of sexual development is another topic where what all can cause ambiguous genitalia in a newborn baby, that we will read. Okay. So partial androgen insensitivity syndrome is called by this name also. Now, a young female present to you with primary amenorrhea, examination reveal normal breast. Again, we are directed to uterus vagina. Absent axillary hair. So you can think of what we are talking about. Pelvic examination show normally developed vagina with clitoromegaly. So vagina is developed but there is clitoromegaly. On ultrasound, gonads are visible in the inguinal region. So what are these gonads in the inguinal region? These are testes. Whenever there are gonads in inguinal region or labia, it is never ovary, it is testis. And absent axillary hair. So it is androgen insensitivity. But they have given you one thing, clitoromegaly. If there is clitoromegaly in a female, clitoris is not enlarged. It will get enlarged only when it is exposed to high androgen. But we were androgen insensitive. Then how does clitoromegaly happen? Let's read the option. Complete androgen insensitivity, partial, MRKH or gonadal dysgenesis. Obviously MRKH is gone, it has ovaries. Gonadal dysgenesis is gone. It should have uterus and vagina. Okay? And secondary sexual characters are absent. It is partial androgen insensitivity. That is why clitoromegaly has happened. Right? Which of the following is best explanation for breast development in patient of androgen insensitivity? What did I told you? I said it was XY which was producing a normal amount of testosterone. But since everything was insensitive, testosterone is not functioning, but FSH, LH are not being inhibited by testosterone. There is no negative inhibition. As a result, testosterone levels are high. And all this high testosterone is going in periphery forming estrone. Now, this estrone is so high that it is leading to breast development. It is different from a normal breast because the nipple and areola are not fully developed, but yes, it is at least tanner 3-4. So, gonadal production of estrogen, no. Gonads to testis and they don't produce estrogen. Adrenal gland producing estrogen, no. Breast tissue sensitive to progesterone, peripheral conversion of androgens. This is the reason. So, we have in detail read the causes, hypogonadotropic, hypergonadotropic, and finally the uterine and vaginal causes. Now, let's see how will I evaluate. See very carefully. Anybody with primary amenorrhea, girl comes to me, what do I want to see? That whether her body has ever been exposed to estrogen. So, if I want to see whether her body has ever been exposed to estrogen, what do I need to do? I don't need to measure estrogen level. I will see an indicator. An indirect indicator is secondary sexual characters, means the breast development. If the secondary sexual characters are present, that is an indication her hypothalamus, pituitary and ovary are functioning. It means I am talking something about uterus vagina. If secondary sexual characters are absent, it means her body has never been exposed to estrogen. So, why the estrogen is not there? For knowing that, I will do FSH-LH. If FSH-LH are high, always the problem is in gonads. And obviously, I have to write here rare enzyme deficiency. If FSH-LH are low, the problem is either constitutional or there is a problem in the CNS. How will I evaluate further? So, how will I evaluate further? If the secondary sexual characters are absent, I will do here what? Ultrasound. In ultrasound, if they are showing me that it is absent, it will lead me to two diagnoses, MRKH or AIH. How will I know? I will do karyotype. If it shows uterus vagina are present but there is a blockage, it means then now I have to see by again doing MRI that whether it is septum or cervical dysgenesis, what it is. If there is problem in ovarian dysgenesis, what will I do? I will do karyotype. I want to know why the dysgenesis. Only knowing that dysgenesis has happened. Ultrasound is showing me streak gonads. That is not sufficient. I want to know why dysgenesis has happened. Because if it is XY, I have to do gonadectomy also. Nothing else. That is why I want to do karyotype. Okay? Right. So, starting with the history and physical examination, any girl comes with primary amenorrhea, what will I ask in the history? I want to rule out the central and the peripheral causes. So, first I will see if there is any central cause. So, I will ask for any anosmia, any visual field defect, any constant headache or convulsions. That will indicate a central cause. Headache, visual disturbance, weakness of limbs. That will indicate a CNS lesion. Then, eating disorder, physical and psychological stress, they all are causes of functional hypothalamic hypogonadotropic hypogonadism. I told you functional. But will it present in such a young girl? Very rarely. Since still you have to take a history. It will majority of time will present once a girl has attained menses, maybe at age of 20, 25. So, it is a cause of secondary amenorrhea. Then, if I am trying to work towards the ovary, what will I ask? I will ask history of short stature. Then, I will ask history of family history. Why I am asking for family history and similar delayed puberty in family? Because I want to rule out physiological delay. Okay, if there is short stature, I am trying to see whether it is Turner syndrome or not. I will ask history of radiation and chemo to see whether ovary has got damaged or not. Okay, right? So this we have seen. What we have seen? Yeah, again let's see that if FSH-LH is normal, is low or normal, I'll do CT scan and MRI. But if FSH is elevated, I'll do karyotype. If karyotype is normal, suppose if karyotype comes out to be normal, if it is X0, it is Turner. If it comes out to be normal, it is pure gonadal dysgenesis. Suppose it comes out to be normal, XX or XY, but it is not a streak gonad. Ultrasound shows normal gonad. I am talking about 17-alpha hydroxylase deficiency. So question gives me high FSH, right? Normal karyotype. Okay, so I was just thinking pure gonadal dysgenesis. Then the question gave me gonads are not streak, normal. Straight away think of enzyme deficiency, 17-alpha hydroxylase. Okay. So further going for evaluation, suppose our evaluation shows it is X0 Turner syndrome. How will I evaluate this person further? We know Turner is associated with certain anomalies for which I have to evaluate the person frequently. So I will do renal ultrasound for any renal anomaly. I have to do repeatedly thyroid function test. So renal anomaly I can diagnose in one go. I don't need to repeat it. But thyroid function test I have to repeat yearly. I have to do fasting, lipid profile, KFT, LFT, audiometry and echo every 3 to 5 years. So remember for Turner. So you will look for thyroid yearly. You will do for echo 3 to 5 yearly, renal anomaly just one time scan, audiometry. इसके अलावा these general, fasting, lipid profile, LFT and KFT. That's how you will evaluate a Turner syndrome patient. How will you treat? All patients, so you have two types of patient. In one, gonads have failed. It can be because of ovary itself, it can be because of the CNS. In one, the gonads have not failed, gonads are functioning, but there is problem in uterus and vagina. So there the treatment is totally different. Somebody, the gonads are not working. This person has no estrogen. So her main problem is she looks like a girl, but she is not developing like a girl. She does not have breast. Can cause a lot of psychological trauma. So I will give her cyclical estrogen and progesterone. Why I am giving progesterone also? Remember gonadal dysgenesis? Remember? And even if it is XX central causes also, they all have uterus. Whenever I am giving estrogen, the main secondary sexual characters will develop because of estrogen. I have to add progesterone because I want to protect this uterus from hyperplasia. I can never give estrogen alone. I can never give estrogen alone in a patient if she has uterus. Otherwise, significant hyperplasia leading to cancer can happen. So I will always add progesterone. The function of progesterone here is only to protect the uterine endometrium. Okay, so I will give cyclic estrogen and progesterone, 0.3 to 0.625 estrogen and 0.5 to 0.1 estradiol. Any of these can be given. Progesterone will be added in the last 10 days. So I can either add medroxyprogesterone or micronized progesterone in last day 12 to 14. In the last days, if I'll add a progesterone, my estrogen will be protected. Patient will start having bleeding. She will start having normal breast development. Okay, so the first thing will be sorted. If it is enzyme deficiency, if suppose it was not gonadal dysgenesis, it was enzyme deficiency, then I need to give her corticosteroids. It was a steroid deficiency. So I will give her corticosteroids along with the estrogens. So remember 17-alpha hydroxylase deficiency, it had excess of androgens, but it had no steroids, corticosteroids, it had no androgens. It has excess of mineralocorticoids, sorry. So what will I give this patient? I will give this patient estrogen, progesterone and also corticosteroids. Remember I told you whenever there is Y chromosome and the gonads are in abdomen, I have to do immediate gonadectomy. So what are the candidates? My Turner mosaics are the candidates. Swyer syndrome is pure gonadal dysgenesis, XY is Swyer syndrome, this patient. Okay, one more patient is there which is XY, but the gonads are in abdomen, XY androgen insensitivity. It is XY pure and the gonads are in abdomen. This is the only indication where immediate gonadectomy will not be done. Remember, androgen insensitivity patient has breast development. She is a confident girl because she looks like at least female. So what is the source of this breast development? This testis. It is producing testosterone being converted to estrone. So I will not do gonadectomy because unless the breast development is complete. This is the only indication where immediate gonadectomy is not done. Here, gonadectomy is done once the puberty is complete. Puberty complete, breast development is complete. Now I can give her estrogen from above. Since her body is maintaining her estrogen, maintaining breast development, I will not intervene. As soon as she reaches the age of almost 16, 15, pubertal development complete, now I do gonadectomy. So this is the only indication where Y chromosome, besides being gonads in abdomen, I am not doing gonadectomy immediately. Okay. What about pregnancy in these patients? So pregnancy in gonadal dysgenesis patients, see, gonads are not working. So no doubt you give hormone, they will start looking like females. But ovaries are not working. So ovulation induction drugs will not be helpful. Ovaries are not all working. So they will need oocyte donation. Remember, they have uterus and vagina. Since uterus and vagina are there, they can become pregnant. But you need to give them ovum. They don't have ovum. Okay. So what will you give? So gonadal dysgenesis patient mein you will give cyclic estrogen progesterone, but for pregnancy you need to give ovum donation. In a patient of a central cause hypogonadotropic hypogonadism, we are discussing it the least because it is very less common. It is not common. So in this also you will give cyclical estrogen and progesterone, but yes, if once you treat the pathology, if there is a tumor, you remove that tumor. If there is constitutional delay, patient will overcome it within the time. The patient can become pregnant because isme gonads are working. Okay. So if you talk about hypogonadotropic hypogonadism, physiological delay, reassure. Kalman syndrome, hormone replacement. Some tumor is there, surgery, transsphenoidal surgery, right? So she can become pregnant if, so problem was gonadotropins are not there. You give her gonadotropins, her ovary is functional, it will start functioning, she will become pregnant. So this is not a major problem. So with hormones, you treat the pathology, and it is something non-treatable, you give her gonadotropins, injections. She will become pregnant also. She will have normal life. Problem is in gonadal dysgenesis, where gonads are not working. You need to give her ovum donation. Now, a patient of secondary sexual characters present, how will you evaluate? Most important, uterus is present or not. So, if there is history of cyclical pain, you know there is obstruction. If there is no cyclical pain, then uterus is absent. History of renal and skeletal anomaly you have to take. Examination may look for abdominal mass, perineal examination, look for any vaginal vulval swelling. Okay. Then ultrasound and MRI will tell you whether it is Mullerian anomaly or not. Skeletal X-ray and IVP and renal ultrasound will be done because it is very commonly associated with MRKH. If the uterus is absent, what will be your next step? Karyotype. Isn't it? So, suppose if there is blind and absent vagina, it is cryptomenorrhea then if symptoms of obstruction are there, either it is imperforate hymen or transverse vaginal septum or cervical agenesis. But if they are asymptomatic, they do not tell you I have pain, they say I don't have pain, it means there is no uterus vagina, it is no cryptomenorrhea. You look for pubic axillary hair, scant pubic hair, androgen insensitivity, pubic hair normal, Mullerian agenesis. How will I confirm? I will confirm by doing karyotype. Right? How will I treat? We have already read. Imperforate hymen, cruciate incision. Means this is imperforate. I will give an incision like that and it will just open the flaps. If it is a septum, then I need to do surgical removal and anastomosis. It's a thick muscle you are removing. You need to anastomose it. Cut. Hanji, ho gaya time? Excellent. If there is if there is hypoplasia of cervix, making the cervix is very tough. So what will do? Uterovaginal anastomosis. What will I do in androgen insensitivity? First, testis has to be removed after puberty. This is the only indication where a gonadectomy can be delayed. Then I will need to create a functional vagina. Remember, they do not have uterus and vagina. So here the main problem is not menses. Menses so nahi hai. Obviously it will never happen because even if you give hormone, there is no uterus, menses cannot happen. They will not. So hormonal treatment will not be given. If the problem is in uterus vagina, hormonal treatment will not help. Hormones are normal in her body. So problem is uterus vagina is not there, the main problem will be coital difficulty. Once you tell her that, ma'am, you will never be able to bleed since you have no uterus vagina. Either it is MRKH or it is androgen insensitivity, you cannot bleed. But the main problem is when you will get married, since the vagina is very short, you will have very significant dyspareunia. So the main problem is creation of a vagina. So here the functional vagina has to be created using procedures like machindovaginoplasty, Vecchetti operation, that we will read when we will discuss Mullerian anomalies. So MRKH is a Mullerian anomaly. So how do we create a functional vagina? That we will study in detail what are the procedures. But important is, can we give hormone? No, hormones are normal. MRKH patient ovary is functioning. In androgen insensitivity, she has estrone. Breasts are normal. Hormone has no role. Problem is her vagina is short. She does not have uterus vagina. She will have problem once she get married. So you have to create a functional vagina. Can she become pregnant? No, because she has no uterus vagina. But yes, MRKH patient has ovary, so she can become pregnant by surrogacy. Androgen insensitivity patient has testis. It is not even a girl. You will not reveal that it's a boy. You will just nurture the patient as she has been nurtured. So if she has been since birth taken care as female, you will just ask her to just stay like a female. You don't need to disclose it. But yes, it's testis. She cannot become pregnant. MRKH can become pregnant using surrogacy. Okay? Let's solve last question. Which of the following should be the next investigation in a patient with primary amenorrhea and normal secondary sexual characters? Obviously, I've said so many times, problem is in the periphery. Hormones are normal. That is why secondary sexual characters are normal. I'll do ultrasound. Right? So this is how we finish our primary amenorrhea.